Hello, everyone, and welcome to today's webinar, Take Action Against Viral HCV by Leveraging Screening Programs and HCV Antigens. I am Marie Stone of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Abbott Diagnostics. To learn more, visit corelaboratory.abbott. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. I'd like to now welcome our speaker, Dr. Mia Biandi, Assistant Professor, School of Nursing, York University. Dr. Biondi, you may now begin your presentation.
Hello all. Thank you so much to the organizers and Abbott for bringing this webinar together today. Really an honor to be here. And as mentioned, I'm an assistant professor at York University and also a researcher at the Viral Hepatitis Care Network out of Toronto General Hospital in Toronto. So just wanted to start off by saying thank you for joining us either live today or later on. Of course, today is World Hepatitis Day, and today we're going to be specifically speaking about hepatitis C. So I'll just go through quickly my disclosures. So these are some of the folks that I consult for or receive fees for, but also just wanted to mention that a lot of the consulting that I do actually goes back into my research program, which does focus on viral hepatitis. So just by way of introduction, I'm sure many of you here know that the WHO signed, and many countries have signed on towards the elimination of viral hepatitis by 2030. And that's obviously incredibly important. But what I want to just mention is, in addition to the morbidity and mortality caused by chronic hepatitis B and C, hepatitis B and C is also increasing in morbidity and mortality over time. So unlike the other three major infectious diseases that we think about globally, malaria, HIV, and tuberculosis, which are all going down, viral hepatitis is actually increasing. And it's becoming a leading cause of liver cancer, certainly in resource-rich settings, as well as in other settings where there may be an underdiagnosis. And one of the reasons why, and just in terms of our why we are coming here today, so really to focus on what we can do, both community-wise, regionally, locally, as well as globally in terms of eliminating viral hepatitis. And of course, you're probably familiar of our tagline here of Hep Can't Wait. So in terms of the reasons why we can actually achieve viral elimination, so although the WHO called for this elimination by 2030, there was actually some particular reasons why it's possible. And so some of these things include the shift of thinking about hepatitis C virus as a chronic disease to now a curable, treatable and curable disease. And that shift has really come for both providers and patients. We also have huge advancements in diagnostics. So this includes things like community-based point of care testing that could be done by a provider, but could also be done by a peer or a health ambassador or community health worker. The thought around reflex testing, which I'm going to spend a good amount of time on in just a few minutes, using dried blood spots to collect samples. This could be serology samples or nucleic acid-based samples. And then thinking really outside of the box, a lot of the world does self-testing, certainly in the context of COVID, as we've seen, but for a lot of other infectious diseases. So thinking about things like self-testing. And finally, viral hepatitis elimination, in particular hepatitis C, is achievable because we have excellent treatment. So we have pan-genotypic treatment. That means it works across all genotypes. And we have very high cure rates in quote unquote all populations. And what I mean by all populations is people who may not typically have had access to interferon-based therapy. So people who use drugs, people who have severe and persistent mental health challenges. And the cure rates in these populations are equal across every group, and so there's no reason to withhold treatment for any particular population. Just because we're going to be talking a lot about diagnostics today, I want to spend a little bit of time on HCV virology. So, as you're aware, this is a single stranded positive sense RNA genome. It's an enveloped virus. I do have the family and the genus listed there. And I just want to draw your attention to the figure there of the viral particle. So, thinking about what we're actually looking at in terms of diagnostics. So, we could be looking at the antibody response. We could be looking at trying to detect viral nucleic acid. So this would be viral RNA by PCR. And then just to point out the core protein there in blue, because we are going to be speaking a little bit about some alternative diagnostic pathways that could involve core antigen. In order to really understand what we're doing in terms of diagnostics, it is a bit helpful to look at the natural history of hepatitis C. And so when we think about an acute infection, we have early infection with a spike in viral nucleic acid, so a spike in HCV RNA. And in that first phase, there is blips, so it goes up and down and up and down. And the same is often mirrored by the ALT response. 20 to 50% of these folks actually do go on to clear the virus, so they clear acute infection, and many then go on to become chronic, and when they are chronic, have leveling out of that viral RNA as well as ALT. At the 3-week mark, this is when we'd recommend people be tested for Hep C antibodies, 3-month mark after exposure. So 12 weeks after exposure is when we'd first look for antibodies after a new infection. And the time frame for acute infection, although it can go beyond 6 months, and some people do clear their chronic infection after 6 months, we typically say people are chronically infected after that 6-month mark. And why that's at least relevant here in Canada is because currently we only treat chronic infections as per Health Canada labeling, but there could certainly be value to treating people when they are in the acute stage. So there's been a major shift in the treatment of viral hepatitis, and I'm sure many of those who are watching this today were treaters or providers in the context of the interferon era. And so in the interferon era, very small numbers of people were being treated, and they really had to have advanced liver disease in order to be eligible because treatment was so intensive. It usually required a specialist, so a hepatologist, infectious disease providers who had a lot of experience in this area. And at least in Canada, our governments had a very extensive paperwork in terms of getting the medications covered. It required a huge team, so a multidisciplinary team that included social work and nurses and physicians. There was frequent monitoring on treatment, and decisions were actually made in terms of on treatment monitoring from a response guided therapy approach. Today, there has been such a huge shift. We have excellent direct acting antivirals, which are all oral. And that's been a really big part of the shift. But because they're all oral and because they're so well tolerated with very high cure rates, we've been able to treat very large numbers of people. So early on, when we had direct acting antivirals, there were many people who were awaiting this therapy. And now what we're doing, we've treated most of those people. And now what we're doing is really working on the case finding aspect. So people are covered, at least in Canada, if they don't have liver disease. Anyone who is a prescriber in our regions can prescribe hepatitis C treatment. So it's no longer restricted to specialists, and nor does it need to be. There are very simple medications, and it's easy for patients and clients to understand. We have lots of practices where there's just a single provider doing the care, often in collaboration with caseworkers as opposed to other healthcare providers. We really don't need to change anything while people are on treatment, so little or no on treatment monitoring. And the medications are extremely well tolerated. And so for those reasons of advancements in diagnostics and advancements in treatment, we really can think about global hepatitis elimination. This is a really nice study that came out this year, early 2022, and it looks at the global burden of hepatitis C, but specifically from the perspective of people who are actively viremic. And so, just drawing your attention to some of the lower prevalence countries versus some of the higher prevalence countries. And this same study actually did a bit of a trajectory between 2015 and 2020, so right before the COVID-19 pandemic, to look at the impact of direct acting antivirals on the prevalence of viremic infections, so people who are actively infected with hepatitis C. And what is actually, I think, a bit surprising to most people who see these data is that in many, many countries, the impact of direct acting antivirals has not affected the prevalence as much as we thought it would. So if a country had a prevalence of 1.9 positivity for viremic infections, it's now 1.8. And I'm going to go into some of the reasons why in a few moments. In terms of people accessing testing, screening, linkage to care, and treatment, there are still sort of three pillars that are really impacting our ability to eliminate viral hepatitis. So there are some pieces at the individual level, at the patient level, and some of these things include competing priorities. So being treated for hepatitis C might not be people's number one priority. It might not even be people's number one health priority. We talk about geographical and structural barriers. So, looking at stigma in healthcare settings, the ability to actually attend appointments, needing to sit for half an hour to many hours in a specialty office, and all of these things can really impact people's motivation to be treated. Not to mention the fact that most people are asymptomatic and so really are not feeling the impacts presently of their viral illness. There is still quite a lot of stigma amongst providers. So even shifting the way providers think about people who are actively injecting drugs is a huge task that we have to work towards in the context of the opioid epidemic, which has affected so many countries globally. This further perpetuates the stigma because people might be reinfected, and providers might make a judgment about those sorts of things. And then there are many systems barriers. So if it takes many steps to get screened and then linked to care and then treated, this access to services, access to what we call low barrier models of care are not present throughout our system. And therefore, people still have wait times. They're still having to potentially travel long distances to seek care. And in the context of telehealth or virtual care in the pandemic, this has made an impact. But those people then really need to have phones and technology in terms of accessing that virtual care. So in Canada, we have set out the blueprint to inform hepatitis C elimination efforts. And there's been this identification of 6 priority populations. And so these populations include people who use drugs or inject drugs, Indigenous communities, those who are criminalized or incarcerated, gay and bisexual men who have sex with men, immigrants and newcomers, and older adults. And by older adults, so we have a mandate to do birth cohort screening. And so in Canada, they've decided that that's 1945 to 1975. But of course, in other places in the world, there's an adoption of screening all adults once, as well as more aggressive strategies if there's outbreaks, including among gay and bisexual men and things like that. And so these are the 6 priority populations that were set out in 2019. But of course, there are going to be new emerging priority populations. So we're seeing that in line with the opioid epidemic, that there are many more new infections in young people, infections in young women. And then there's, of course, a lot of overlap in these, we're calling priority populations. So among people who use drugs, who may also be newcomers to Canada, or and that intersectionality that often exists in so much of this work. And you might be hearing or interested around that screening and pregnancy aspect, which I think is becoming a real thought-provoking discussion around screening and treatment in pregnancy. And although we can't intervene in pregnancy, there is this opportunity to link people to care while they are pregnant, because it might be the one time where people are seeking care. The impact of COVID-19 on hepatitis C testing, of course, has been tremendous. It's been quite significant. And these are just two studies from two different provinces in Canada, where I am. So one in British Columbia, one in Ontario, to really show that exactly in line with the shutdowns of the provinces, there were huge drops in testing, so screening and diagnosis for hepatitis C. And although they came up throughout the rest of the pandemic, so in our Ontario study, we looked at the first wave, the second wave, and the third wave, they had not reached pre-pandemic levels. And what I would suspect is, with the wide adoption of virtual care and getting a bit back to normal, certainly we are probably closer to where we were pre-pandemic, but we have definitely not fully rebounded. And in terms of treatments were actually going down even prior to the pandemic. And so the pandemic just further exacerbated an existing problem. I really like to talk about the care continuum when it comes to looking at the pre-treatment cascade of care for hepatitis C. And it's really just to hone in on the fact that there are so many steps for people, from screening to cure. And we can really spend a lot of time thinking about how we can reduce the number of steps. So I think in a perfect model, in a non-cirrhotic population, treatment can be initiated certainly in 2 visits. But what often happens is something more similar to what you're seeing here, where an individual is seeing a provider, they need to go get labs, they need to speak or see the provider again, maybe they need more labs or imaging or a FibroScan. And at each one of these steps, that LTFU, there's the potential for loss to follow-up. And if this individual at the top that they're seeing as a provider is also a non-specialist, and at any time is uncomfortable with the care, they might think about doing a referral, which is completely appropriate. However, every time we refer, we also lost a follow-up and a barrier to treatment and care. And even though we've done a lot, I think, as people who work in outreach settings, to really decrease the number of steps, like using point of care antibody testing, drawing blood on site, or using dried blood spot collection, COVID impacted a lot of these systems that we were creating to decrease the barriers to care. So perhaps we weren't able to go in to see people where they were being housed or where they were going and dropping in for food. And so we lost this access point where people were already seeking another service and our ability to screen and treat for hepatitis C. This is a really nice study that I just wanted to bring your attention to. It was a global survey among hepatitis providers and program managers to look at what was the impact to the services delivered for hepatitis C during the pandemic. And a lot of the concerns were actually, of course, at the staff level. So loss of staff, limited staff, fear and anxiety among patients, lack of PPE, and supply shortages. But I think we can all appreciate that out of this pandemic, there's actually been some streamlined pathways to care. So perhaps people that used to feel that they needed to do a FibroScan in order to treat someone for hepatitis C realize that they don't, and they wouldn't be able to in the context of the pandemic. There might have been more emphasis on really thinking about our testing platforms, because there was such high volume testing for COVID. So can we replicate that for hepatitis C as well? Really speaking to colleagues in terms of the referral networks, and really thinking about, how can we improve training? How can we have people who are doing COVID testing also doing hep C testing, and really co-localize that care? In terms of some of the models that I work in, so we kind of think about this as our hepatitis C pathway to care. And, we could have referrals from outpatient clinics or emergency rooms or primary health care or sexual health. But most of our testing and diagnosis comes from street outreach, from screening people where they're at in other types of services like opioid agonist therapy or trauma-informed drug rehabilitation. And so we really see ourselves as sort of that central access point. But what I wanted to mention was our program is only really successful because it's entirely self-referral. So it's entirely just to call the provider, very low barrier. They can often speak directly to the provider without having to leave a voicemail or wait on the phone. And this has been extremely helpful. We also are really advocating for moving forward on other types of communication. So certainly in the context of virtual care in the pandemic, many clinics adopted video-based care, phone-based care, and we've always been advocating that we need to do more text-based care and email-based care because it might be the only way that we can reach individuals. In terms of other types of settings like the correction system, certainly, we've had challenges in Canada around treating in correctional-based systems, but there's also a thought around universal screening in that types of environments, and then, of course, universal screening in other environments where there might be a high prevalence. Traditional in-person care is still sometimes desired, depending on the population, but we found that essentially we need to offer a menu of approaches and then determine how the person wants to move from that point onwards. So, although all that sounds a little bit complicated, our simplified model for HCV care really only has three components, and this is where we've sort of been the most successful. So, we need an opportunity to actually provide care. So, what does that look like? What does that mean? Well, that could be again in a opioid agonist therapy clinic, that could be in drug rehab, that could be in medical detox, that could be while people are incarcerated. So, what is that opportunity that we're going to be able to provide care, provide screening, provide treatment? We've also found that a major aspect to all of our programs is engaging peers, or people with lived experience. And I use the word peer in sort of a broad perspective, but it could include people who have experience with hepatitis C, but it could also just be people who have a shared journey. So, if we're doing a program with women who have experienced violence, that our peer might have had some of that shared journey. The same would be true of people who use drugs or people who have been incarcerated, where we know these models are really the best way to reach individuals. And then we need some sort of clinician involvement. So that could be nurses, that could be physicians, that could be social workers, but just having that aspect of clinician involvement. And in our programs, which are extremely low barrier, the clinicians are really in the background, actually. So the peers are usually leading the programs, and the clinicians are doing some of the oversight. But most of the care is really driven by that peer-led model, which is at least where we think we need to be to eliminate viral hepatitis. But this whole pathway starts with a testing algorithm. So just as a reminder, our first test, our screening test for hepatitis C, is an antibody test, so anti-HCV. And if individuals are positive, of course, that means that they've been exposed. And just as a reminder that they're going to be antibody positive for life. If they are negative, we usually recommend screening every 6 months if they have ongoing risk factors. Now, I don't have anything here about reflex testing, and I will get to them in a moment, but the next step after antibody positivity is going to be confirming active infection, and that can be done in multiple ways. And so I want to start to introduce you to some other ways where we might consider confirming active infection. If they're actively infected, it's helpful to get a genotype. Sometimes you don't need it, but you might want it in a cirrhotic population. And one of the most interesting things about viral hepatitis elimination, I think, is that, really in order to achieve it, we're going to have to address this undiagnosed fraction. So in a place like Canada, we propose that our undiagnosed fraction is somewhere around 44%. But based on the literature, in a lot of countries, the undiagnosed fraction could be up to 95%. And then in countries where there is some robust screening and treatment is readily accessible, we still are struggling towards that elimination goal because new infections are actually outpacing the number of individuals who are cured. When we think about testing, we really need to just sort of break down the testing modalities. And so, just as a reminder, when I'm speaking about these different testing modalities, so hepatitis C, antibody positivity, it's the body's way of showing that it's seen the virus before. And in the context of some viruses, it could be exposure or infection. And in Hep C, we wouldn't know until we went to the next step. Hepatitis C core antigen. So, an antigen, just as a reminder, is a protein, it's a piece of the virus. If you can detect the antigen, that means there's virus there. And then nucleic acid based testing, which even the public has become extremely comfortable with, PCR testing for COVID. And so that's exactly what we mean. We're looking at PCR testing, nucleic acid based testing for viral RNA, so hepatitis C RNA, which is the presence of the virus. And again, is that active infection. And in some regions, that test could just be a positive or a negative, or in some regions, that test would be quantitative and would be known as a viral load, a quantitative measurement, which can either be in international units, so IUs per ml, or copies per ml to give the viral load. And the only thing that I'll leave with on just speaking about the viral load is that we're still addressing a lot of the myths in the community around the relevance of viral load. So there are still many providers that would think that hepatitis C is similar to hepatitis B, where the viral load could affect progression to advanced liver disease, and that people with low viral loads may not need to be treated. And of course, that's not correct. We should treat anyone who is positive for the virus. So I'm going to use this term moving forward, reflex testing. And it's really to say that, reflex testing really needs to be thought of as the gold standard. And luckily, a lot of major labs globally have moved to reflex testing. I'm going to speak a little bit about the Canadian landscape in a moment, but reflex testing means that the sample that's been tested for Hep C antibody is the same sample that's used for the test of active infection. And that has extreme importance, especially in a difficult to reach population. So when we think about our testing toolkit, we might consider starting off with a traditional venipuncture based antibody test. This is helpful to be used when the costs of point of care testing are too great, and there is that ability to send to a high volume testing lab. But that sample really needs to be reflexed to either a core antigen test or PCR-based testing or looking for viral nucleic acid. And I'll sort of discuss why you might consider one or over the other in various environments. But this quote unquote reflex testing eliminates the need for two tests. And I'll just speak about why that's so important in a moment. So I'm sure that we don't need a crash course in PCR. Again, with COVID, we've spoken so much about it, but I do want to talk a little bit about looking at that antigen-based testing. So HCV core antigen testing is commercially available. It's a chemiluminescent microparticle immunoassay, and it looks at active infection. So it's just as I mentioned before, the presence of antigen means active infection. The limit of detection is 3 f-moles per liter. And in terms of the studies around sensitivity, I just want to preface this by saying there has been a lot of investigation into this assay, and the sensitivity is around 94%, although there's really a viral load cutoff. So when the viral load is higher than 3,000 IUs per ml, the sensitivity approaches 100%. And the specificity, so the ability in order to rule out false positives, actually approaches 100%. This is some work that we've done that's on the right-hand side of the screen there, looking at the diagnosis stage and then the stage for cure, which is SVR, or sustained virological response. And just wanting to point out that in terms of the correlation between core antigen and HCV RNA, they are extremely well correlated. And so that's sort of the science behind, whether or not we should be using this test. But in terms of the practical reasons why we should be using it, it really keeps the reflex testing in the serology-based pathway. So if we're concerned about, as laboratorians or clinicians, about RNA degradation and how that might affect sensitivity, by using core antigen that really keeps it in the same serological pathway. And this is sometimes helpful in high volume labs that have a sort of a serology section, and then which is separate from the nucleic acid based testing section. It's also less expensive. So I won't speak extensively about the cost effective analysis, but our group has done a bit of work just around the costing. And it's not just less expensive for the lab because the reagents are less per test, but it's also much less expensive to the system. So when we did some modeling, at least in where we are in Canada, it's 5 times less expensive to use an antigen test over nucleic acid testing. And in a lot of environments, especially in our currently stretched healthcare system, this is really something to consider. So why should reflex testing actually be the goal? Why did I say that at the beginning? Well, depending on the population and the study, the number of individuals that are lost to follow-up between antibody testing and determining if they have active infection is anywhere 30 to 50%. So 30 to 50% never move on to that second step in the cascade of even knowing if they're positive or not. And I think it's very interesting from the patient perspective and sort of the diagnosis that they've been given, because I have had so many patients that certainly believed they were hepatitis C positive, and they were, but all we actually knew was that they were positive by antibody testing. And so that aspect of confirming the active infection is often lost among these difficult to reach populations. We should really be considering which modality is the right test for the right environment. And so when we think about, approaches to diagnostic algorithms, there are a few things that we really want to consider. So one would be, what is the prevalence in that region where we're going to be doing the testing? What is the testing setting? And what I mean by that is, are we doing it out of the trunk of a car? Are we doing it in a mobile van? Is it in a shelter? Is it in a traditional clinic? What sort of options do we have available? Can we do point of care antibody and dried blood spot, or is this all going to be going to high throughput labs? So really thinking about what is the mixing and matching that we can do between antibody testing, nucleic acid based testing, and core antigen testing to really maximize that testing algorithm, and then looking at costs. And what I want to say here is, in the context of nucleic acid based testing, in certain parts of the world, the cost of the test can actually be more than the cost of the treatment. And so you can imagine that in some regions of the world, it's even more cost effective to treat just based on a positive antibody alone without even knowing if an individual is actively infected. But using core antigen can actually give us that information around active infection as well as decrease the cost. So we've been looking at this in Canada and really trying to look at the differences from region to region or province to province around what different provinces are doing in terms of their testing algorithm. And unfortunately, we still do not have all provinces doing reflex testing. So 3 provinces are not doing reflex testing in terms of nucleic acid based testing, but one of those provinces has incorporated Hep C core antigen testing to be that reflex test and actually keep it in that serological pathway, as I mentioned. We still have 2 provinces, and I'm living in one of them in Ontario, Canada, where there is not yet any type of reflex testing. And we absolutely see this drop off of 30% of individuals who never get confirmation of active infection. 2 provinces in Canada very astutely incorporate core antigen testing into their algorithm, and I'm going to go just show you what those look like. So those are in the provinces of Saskatchewan and Manitoba, and what they've decided to do is, for anyone who is antibody positive, they actually evaluate the cutoff for antibody testing to decide if they're going to report it as negative or if they're going to progress on to requesting another sample, or in Manitoba, using the same sample for HCV RNA testing. And this allows basically a triage effect in terms of the testing algorithm, which is cost saving. And just in terms of thinking about, what are the right tests for the right populations and the right reasons, I wanted to help you consider 3 ways that we could maximize our testing algorithms. So the first scenario would be a person is tested for antibody. If they are negative, no further testing is required. As I mentioned, you might consider retesting them in 6 months if they have active risk factors. But after an antibody positive test, moving on to a core antigen test. And so if core positive, we know positive, they're actively infected, linked to care, or maybe they've been treated and we're actually evaluating for viral relapse or treatment failure. If they're core negative, we could consider doing nucleic acid testing on all samples, which is a bit different than what I mentioned around using the antibody cutoff. And again, if positive, link to care or evaluate for relapse, and if negative, future testing is clinically indicated. And what I mean by that is if there is a high degree of suspicion that they have a low viral load, and you might be missing them with the core test, and their HCV RNA undetectable, you may want to consider retesting them in 3 to 6 months. So some of the advantages is that by using the core testing after antibody testing, we eliminate this initial concern around RNA degradation. And this has come up often. It comes up often with laboratorians around how long can the sample sit in the fridge before it'll impact the viral load, and will that make a sample go from positive to negative? When we think about diagnosing chronic infection, we actually should be considering, what tests are the right tests for each individual stage in the cascade. So there's the diagnosis stage, there's also the test of cure stage, or the SVR stage, and we could be using core antigen for both the first test as well as the test to confirm chronic infection, so 6 months later. And then I just really want to point out, as I mentioned in this algorithm, that when somebody is core negative but RNA positive, that person likely has a viral load that's very low, so anywhere less than 3,000 IUs per ml. And interestingly, when many studies came out about the use of core antigen testing, the WHO looked at it from a global perspective of how many individuals might be missed in this scenario, and only about 5% of individuals have a viral load that low. And the really important part is that most people will not have a viral load that low ongoing. In terms of a different type of scenario, so in this scenario, we actually have no nucleic acid-based testing at all. So thinking about after an antibody positive test, progressing on to a core antigen test if they're positive, linked to care or evaluate for treatment failure or viral relapse. Are they core antigen negative? And then not having the option of nucleic acid-based testing, which I'll go into some of the reasons in a moment, but just thinking about, okay, they're negative. Do I have a high degree of suspicion? If yes, retest by core antigen in 3 to 6 months. Some advantages here, again, eliminates this concern of RNA degradation. And where this is particularly important are in regions where samples will not be immediately tested. Perhaps there's a distance which they need to be shipped. Perhaps those storage conditions are not ideal. So it could be like us in Canada, where it's shipped for a couple of days from very cold temperatures, or in other regions of the world where the temperatures are extremely warm. Also, just to speak to the cost again, so why is there no nucleic acid-based testing in this algorithm at all? Well, again, it speaks to the fact that in some regions of the world, nucleic acid-based testing is so expensive, more expensive than the cost of the treatment, that it's simply not doable to incorporate this modality into the testing algorithm. The third scenario, which I think is a pretty exciting scenario, and I think probably where we need to move to, is to get rid of antibody testing among populations and in regions where the prevalence is extremely high. So by that, I mean anywhere from 10 to 50%, which we might see in a population of people who use drugs or a population of people with severe and persistent mental health issues. And so actually screening with core antigen. So can you imagine just a single test to look for active infection? And so, yes, we will not know about their exposure status, but we will know if they're actively infected, which is truly what we really care about. So this could be used in places like opioid agonist therapy clinics or supervised injection sites, overdose prevention sites, or in parts of the world like Canada, we actually have safe supply programs. So this is when we prescribe opioids so that they're not tainted. And these folks might have a higher prevalence of Hep C. So knowing immediately if they are actively infected could decrease the time from diagnosis to treatment. Another thought would be to use core antigen testing for people that we already know are antibody positive. So looking back at our databases if we have them, or we already know their status, and maybe they've even been treated. And so we could look at this core antigen test from a test of cure perspective, or using for SVR, or looking for reinfection. So in that population that are known antibody positive because they've been diagnosed, they've maybe been treated, and you have a high degree of suspicion that they failed therapy or they're potentially reinfected, which we're seeing so much coming out of the pandemic, using core antigen as that rescreen for active infection. And again, just to speak to the fact that the costs might be so high for looking for reinfection using nucleic acid-based testing or PCR-based testing, that this is a time where we really want to consider using core antigen testing. I just like to end with a couple of conclusion slides. So in terms of our model, we really look at this that we need to test and treat people where they are at in life and location. So our work really incorporates every single aspect of social services, looking at things like training primary care providers, making them aware of different modalities for testing, diagnosis, and treatment. And in primary care, thinking about things like testing every new patient, using it in the context of I'm already ordering blood work, so I'll order Hep C screening. Thinking about people that do have risk factors, and thinking about people that have other types of liver disease like alcohol or fatty liver. In terms of a mental health or corrections scenario, so certainly using core antigen testing in a region that would have a high prevalence or a location that it would have a high prevalence like corrections could certainly make sense. Some inpatient mental health studies have shown that prevalence can be as high as 15%, and that it would hold true in community mental health settings, and of course, much higher in addiction settings. In terms of outreach, so this is what I mean by meeting people where they're at in life and location. Hep C might not be on their radar whatsoever, but if we can work with them in terms of where they're at in shelter, in drop-ins, in pharmacies, we've seen the incredible impact in Canada of engaging our pharmacy colleagues to do screening and testing for COVID, and we should be able to do the same for hepatitis C. Thinking about doing home visits, gosh, driving to someone's house and having them tested in the comfort of their own home, looking at newcomer and immigrant social services sites where we can work with folks, and then working with people who have experienced violence, who are very unlikely to seek care and might have been stigmatized in the past. And then finally, thinking about your tertiary care settings, not to leave tertiary care settings out, but to think about them in a different way. So in the past, we thought about tertiary care settings as the place where we would diagnose and treat hepatitis C. And now we can be looking at tertiary care settings as places where we can actually screen universally for Hep C. So thinking about emergency rooms and then other populations which will have overlapping health complications from hepatitis C, like our diabetic population who most often has fatty liver disease, that obviously treating them for hepatitis C would be advantageous. Looking at those in renal failure in cardiology clinics, and then, even thinking about out of the box thinking like obstetrical practices, geriatric practices, and pediatric practices. Of course, in the context of testing, it's not a one size fits all approach. We really need to evaluate these individual scenarios, these individual settings for what's the best algorithm for each of these populations, because that's really what this is all about. This is about meeting the individuals and working with them in the way that they want to receive care. I'll just end off with a couple of sort of take home conclusions around the screening and diagnosis aspect of the talk. So, one thought would be around optimizing testing and how can we do that? Well, we really should think hard about incorporating core antigen into our testing algorithms. So, moving from antibody positivity to reflex testing, this helps us keep this in this serological wheelhouse when Hep C RNA testing is not readily available, when samples need to be shipped, or when it's too expensive. Thinking about core antigen testing as a first screening tool, I really do hope we get there. I hope we can wrap our heads around using core antigen or other measures of active infection for an initial test, because in a population that has a very high prevalence of antibody positivity, it might not be that helpful to be screening these folks by antibody testing. And then in terms of repeat testing, so we could be using core antigen to establish chronicity, as well as looking at test of cure and then testing for reinfection. I did present some work from our group today, and so I just wanted to acknowledge many of the authors that were involved in the work that I presented. And again, just to thank Abbott and LabRoots for hosting this webinar today. It's been an absolute privilege to be here with you, and I'd be happy to take any questions.
Thank you, Dr. Biondi, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many of your questions as we have time for. Let's get started. Our first question is hepatitis spread through saliva?
Yeah, so as far as we know, it is not. One thing to think about in terms of oral hygiene is that if people had gingivitis or bleeding gums, that it could be transmitted by things like sharing a toothbrush, because there might be small amounts of blood on the toothbrush and then the other individual uses the toothbrush. That being said, there are some testing modalities and some investigation into saliva-based or buccal swab testing for Hep C, but not transmission. Thanks, good question.
Thank you. Next question. Who would be missed by core antigen testing?
Yeah, so I think it's a really important question, because when we talk about sensitivity, I think as laboratorians, we really want perfect sensitivity, and we find it challenging to not accept that close to 100% sensitivity. And of course, the data I presented here today was based on a few different studies that had an average sensitivity of about 94%. But when when samples that had higher viral loads beyond that threshold of 1,000 to 3,000 IUs per ml, sensitivity approached 100%. And so this is extremely important to think about, because in the context of all of those individuals with chronic hepatitis C, as I mentioned, only about 5% are going to be below that cutoff. So certainly we might miss some acute infections, but if our goal is to treat those chronically infected, we will not miss that same 6% as we think we will, because most people with chronic infection will have a viral load above that core antigen cutoff.
Thank you. Next question. What role does testing play in reaching HCV elimination by 2030, especially considering the need to recover from COVID-19?
Yeah, so I mean, what we showed in Ontario is that testing went down by somewhere around 35% in the context of COVID 19. Additionally, COVID 19 has put tremendous pressure on our healthcare system and on the diagnostic system that we had in place. So, there might be some advantages that we can see from that. So, we've created really good lab based testing pathways to optimize screening for COVID 19. And so, one thought in terms of recovery would be to leverage some of these pathways, including new equipment, and use those same testing pathways and those same pieces of equipment for increasing our ability to screen and test for Hep C. I think in an outreach setting, if you take nothing else home from my talk today, it's that reflex testing is essential.
Thank you. Next question. If parents are infected, how do you prevent their baby or their child from having hepatitis?
Yeah, so unlike hepatitis B, household transmission is not as common. And so, outside of those pieces that I mentioned about toothbrushes, sharing nail clippers, sharing tweezers, sharing things that could have small amounts of blood, household transmission is not common. However, when we think about parents and we think about pregnancy, vertical transmission is actually 5%. And in the context of an HIV hepatitis C co-infection, can approach 11 to 12%. We just published a study to show that there's a potential that viral load could actually increase the potential for vertical transmission. So, in the context of parents, I think what we're really exploring now is around women who have hepatitis C in pregnancy is should we be intervening in pregnancy? So not just screening to know, but should we actually consider treatment in pregnancy? And if we're not comfortable considering treatment in pregnancy, we definitely need to treat in the postpartum period. As we understand it right now, most women are not treated in the postpartum period before they become pregnant again. So we could treat postpartum and then eliminate any risk of ongoing transmission in terms of that vertical context.
Thank you. Next question. Which hepatitis is most dangerous, A, B, or C?
I feel like that's a loaded question, perhaps by an individual who already knows the answer to that. Yeah, I think it really depends on the population that you're looking at, and of course, there is some overlap in terms of the populations affected by A, B, and C. But when we think about Hep A, so this is often either in endemic countries, and it has a great impact around young children. In terms of our settings in Canada, so people are impacted by hepatitis A in the context of experiencing homelessness. And certainly they could have fulminant hepatitis and they could have an extremely significant disease. But most people with hepatitis A actually never know they have Hep A and so do not necessarily go on to liver failure. B and C are obviously different routes of transmission. So, in terms of answering the question, for hepatitis C, people are unlikely to have acute liver failure leading to cancer. And with hepatitis B, we might have a similar scenario around, low risk of going on to hepatocellular carcinoma, whereas Hep A would be that acute, significant viral illness. But I think the scary thing is that most people with hepatitis B and C do not know they're infected and do not know they have symptoms. And so with A, people might have an extremely bad course of disease. They could become quite sick. Most will recover. But for B and C, if we don't screen, people will go on to have, liver failure, liver cancer, and that potential is really there. And we don't always know who's going to go on to have significant liver disease. And so for me personally, that's why I think it's extremely scary in terms of answering that question.
All right, thank you. Um, Next question. Would it would it be useful if the HCV antibody rapid test for screening and then confirm the positives with HCV antigen?
Yeah, I think it's an algorithm that could make sense. So, in an outreach setting where point of care antibody is ideal to do that test on site and then draw labs for core antigen. I think that makes a ton of sense. But I think the thing to consider is that the cost of the point of care test is actually quite high. So, at least in our Canadian market, it's about $30. And compared to core antigen, which I sort of mentioned in our Canadian market would be reimbursed at $15, that's half the cost. So I think when you think about the whole pathway, you need to think about which populations are you testing? Is there a high likelihood that they're going to be antibody positive? And if so, maybe we just skip. That being said, someone knowing that they're antibody positive can at times be an engagement tool. So if people know they're positive and they get retested, they might be re-engaged into the care cascade and more likely to get linked to care, treated, and cured.
All right, thank you. Next question. Is it possible for an individual to contract a mixed hepatitis infection?
Yeah, certainly. So in terms of viral hepatitis, maybe I'll just speak to viral hepatitis because, of course, there's other types of hepatitis. In terms of viral hepatitis, we actually want to be really proactive in this arena. And so, for people that have hepatitis C, we encourage providers to look for Hep A and Hep B infection immunity in the context of Hep B infection and for both immunity, because we have a great tool to vaccinate individuals so they don't have Hep A while having Hep C. In terms of viral co-infection, so B and C together, this is possible, and we do see it. It's not as common because the viruses do compete for replication in the hepatocyte. And certainly, there is also a predisposition where having one viral hepatitis, so C, might lead to less Hep B just because of that competition. So it's possible to see a true co-infection, and it's certainly a part of our workup for treatment to make sure they don't have a co-infection, but it's not very common.
All right, thank you. And it looks like we have time for one more question. What about a combo HCV assay, antibody plus antigen, like we have for HIV? Would it be useful?
Yeah, again, it kind of goes to what I was saying before. I think it's useful in certain settings. So I think it could be useful if the cost is reasonable for that setting and if it makes sense to do the screening test at all. So, in the context of HIV, it's a little bit different because, of course, an antibody positivity is indicative of infection. And so, even though we do this in our fourth generation HIV assay, so antibody testing plus antigen testing, we're really looking for infection there. In the context of Hep C, it could have utility for screening, but if we already know people are antibody positive, which I mean, at least where I am in the world, people are tested sometimes 5 times for antibody positivity. It might not be that helpful. So I think it does really depend on the intention of the test and this ability to mix and match. I just can't emphasize that enough because it's not going to be a one size fits all for this population.
All
Good
right,
question.
thank you. Thank you, Dr. Biondi. Do you have any final comments for our audience?
I just wanted to again say thank you for joining me today in the context of world hepatitis and really thinking about elimination. This is really grassroots work. This is really working within your community, with working within your network, and then getting that political advocacy and engagement. So you've taken the first step by coming and attending here today. And please feel free to reach out to me for any additional questions and follow up.
Well, thank you again, Dr. Biondi, for your time today and your important research. We would also like to thank LabRoots and our sponsor, Abbott Diagnostics, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone, and goodbye.